At the outset, I would like to thank for giving me this opportunity. So, I think postoperative PH is a challenging and a feared complication of any congenital heart disease surgery. And the most severe manifestation that is generally known as pulmonary hypertensive crisis are the acute right heart syndrome, where there is a right heart failure followed with cardiovascular collapse. This can be of three types. One, it can be a persistent PH, or it can be a progressive PH, or there can be a de novo PH that is happening in the postoperative period. Like, for example, in tetralogy, if you do a VSD, there's a new onset PH that can happen. It's a daunting therapeutic challenge. There is no doubt about that. It occurs sporadically in individual institutions. So most of the times there is varied approach to the treatment, and most of the times it is not an evidence-based treatment that we all following. It is associated with a very high mortality. So how common is such a postoperative PH? Some of the studies in the 2000 published in 2002, a large series from a large center, suggested it's around 2% of all CST surgeries. Possibly it may be encountered more in India because of delayed surgeries and all those stuff, but we don't have any data from India. So what is the pathophysiology of the worst complication, that is the PH crisis? So there is classically evidence of RV hypocontractility, elevation of RA pressure, RV systolic dysfunction, and shock. The compensating mechanisms fail, and the RV systolic dysfunctions, the function worsens, and then there is a decompensation. The LV preload actually decreases, and then that actually abolishes cardiac output and coronary perfusion. So worsening hypoxemia and acidosis further exaggerate this vicious cycle. So ultimate cause of death is right heart failure, and the right heart failure ability of the right heart to handle the added strain and the augmented pulmonary artery pressure is a critical thing. We really don't know why some RVs fail while others are able to cope very well with a high PA pressures and the patients come up without a PH crisis. We really don't know. But for the people who know understand physiology, an acute PH RV cannot tolerate or generate more than 40 mm of Hg in terms of pulmonary embolism and all. So in terms of pathophysiology of PH crisis, it's a more complex than just PH. So the RV contractility, RV ischemia, elevation in RV EDP, that progressively increases the LV EDP, that decreases the stroke volume, and then that reduces the blood pressure and coronary blood flow, ultimately leading to low cardiac output. With a lot of other contributing factors like starting from age, dysfunctional endothelial cells, sepsis, CPB, and so on and so forth. There is not many things shall be coming to in detail. So the ones that are very important that we should all remember is the presence of preoperative pulmonary hypertension. It's one of the most important predisposing factors. And the fluid status, left ventricular systolic or diastolic heart failure, and acute lung injury and acute respiratory distress syndrome, pulmonary embolism, acidosis, and hypoxia are the most important ones that all clinicians should keep in mind. So coming into which lesions produce this pulmonary arterial hypertension crisis. So this is a very old study, but still it is relevant. So surprisingly, some other studies, like some of the lesions like EAPVC and truncus arteriosus are supposed to be associated with a lot of PH crisis. But with the advent of modern anesthesia and modern techniques, I think the numbers have come down. With the VSDs and AVSDs, especially with pre-existing PH, are the ones that are mostly associated with reversible PH now. So what are the exact triggers for this kind of a PH crisis that develops? So the exact triggers are not completely understood. Preoperative PH is a very, very important characteristic. And there also, like closing a VSD is likely to be associated with, more likely to be associated with a postoperative PH than closing an ASD, especially the crisis part. And AVSDs are much more commoner. And then people who have Down syndrome are more common to have PH crisis. So the key to the whole things are endothelial cell dysfunction, both preoperatively and postoperatively, and the inflammatory response and ischemia reperfusion injury to CPB, and even some simple pain and awakening reaction in mechanically ventilated children, even tracheal sections and the tracheal secretions can actually trigger PH crisis. So how do you evaluate and how do you manage a PH crisis or a severe PH in a postoperative situation? So the three things that we want to look at is what is the effect on the whole hemodynamics? So is there a systemic hypotension? Is there hypoxemia? Is there evidence of low cardiac output and tissue hypoxia? That is number one. Number two, is there any precipitating factors or aggravating factors removing which the things can be corrected? Like, for example, before you jump on the gun for specific therapies, you rule out infection, acidosis, arrhythmia, and pericardial effusion. And then rule out other causes that could explain the symptoms of thing rather than just the heart surgery, like, for example, pulmonary embolism or pneumothorax. These are the major crux of evaluation that we should follow. And the gold standard is always echocardiography, even though X-ray and ECG may help in ruling out some of the causes. But the gold standard is echocardiography, and oftentimes we rely upon the tricuspid regurgitation, the pulmonary regurgitation velocities. Always, as a clinician, we should remember that these can be falsely low in the presence of RV dysfunction and circulatory collapse. So that's a big challenge. So TAPSE is, out of all the other parameters of RV function, TAPSE may be quite useful, but it's not very well studied in this situation. So one important thing because which has a lot of meaningful information, that gives a lot of meaningful information in terms of how do you manage the patient, is RV and LV function. So both systolic and diastolic function, and a critical look has to be made into the LA volumes and the RA volumes. IVC assessment is important as part of the fluid management and the amount of right heart failure that is setting in. So always, before we start treating the pulmonary arterial hypertension, always look for structural causes depending on the surgery the patient has undergone. So some of the structural causes one should not miss include in a patient who is suspected postoperative PH. It should be residual lesion like an apical VSDs or additional VSDs, or a residual VSD that has been missed, a PDA or an AP window that has been missed, or pulmonary vein narrowings that have unraveled post-surgically, or that was missed preoperatively, mitral valve lesions, the ventricular dysfunction that has set in. Always look for LSIs here. As again, I told you, the ventricular and AV valve hyperplasia, walked and arch issues. So always keep a checklist in your mind that always run through all of them, chamber by chamber, and then never miss out on RUOTO that was earlier missed, and then that is actually causing the high velocity of TR, peripheral PS, pulmonary embolism, lung causes. Even though these are all unusual causes, they are very rare. But still, if you are in a very high volume center, once in a year you will find all of them causing what is so called residual pH in a situation. For example, we in a postoperative tetralogy, we realized we are dealing with some residual VSD or some pH crisis, but then we realized it's actually an acute AR that was actually producing the whole issue, and the patient underwent an AVR along with it, and the patient recovered finally. And then even arrhythmias also well known to increase pulmonary artery hypertension. And then post-quantum and post-blend present different issues, which I will not be going into the details. Other evaluations could be BNP and anti-pro-BNP, fluid status, and vital organ function with all your LFT, RFTs. CT angiography if you are suspecting pulmonary embolism or peripheral PS or pulmonary vein issues or lung or airway issues are suspected, then CT angiography could be useful. BQ scan if you are suspecting pulmonary embolism, and pulmonary artery catheter placing, it could be a useful thing. And same way, right heart catheterization can give a lot of information, but actually they are not evidence based. We don't have evidence that such invasive monitoring helps in this kind of pH crisis. So how do you manage? So first and foremost thing is, like, just to look at the TR velocity is high, don't jump the gun and start Belrinone or start sildenafil, or put the patient on an NO ventilator. Always look for reversible causes, both structural and physiological. So always correct the structural causes if anything is found, and then reverse and optimize the physiological status. If nothing works, then you consider specific therapies. And in mild to moderate pH, most of the time when they have a stable hemodynamics and preserved RV function, so optimizing, ruling out structural issues and optimizing the physiological status may be good enough, and considering simple therapies may work, and then that could be good enough for managing. But the problem comes in pulmonary artery hypertension crisis, where I think it's a lot of things are going wrong. Unless we act fast, we miss the bus. So the basic goals of therapy are lowering the RV afterload, augmenting the RV preload, and improving the RV contractility. So how do you do that? Most important things are the basic things, the boring things, the basic ones are more important in this situation than the fancy drugs. I think fluid status, it's a preload dependent situation. Both dehydration and overhydration are harmful. So you should try out boluses. And always remember, ventricular interdependence plays a very critical role in such critical patients who have compromised RV. And in such a situation, monitoring wedge pressures and monitoring right heart catheterization could be of use. Correct acidosis, hypoxemia, and anemia. In terms of anemia, we don't know the optimal hemoglobin in this situation, but we all know that possibly less than 9 and greater than 18 in a cyanotic congenital heart disease are undesirable. So in a patient who is not ventilated, oxygen is a potent pulmonary vasodilator. But in the absence of hypoxia, this role is not proven. And then in a patient with cyanotic congenital heart disease, target may be lower, as we all know that. Alkalinization has been proposed as a therapy for pH crisis, to give sodium bicarbonate to achieve a pH of 7.44. But it generally is useful in the presence of other inotropic and vasopressor drugs are being given. And then there are some reports suggest that prolonged alkalinization may actually be harmful in newborns and neonates. So sedation, generally anxiety and agitation increases the PVR and oxygen consumption, and it has to be done with caution. So anesthesia and ventilation plays a very, very critical role, and it has to be a tailored approach. One size doesn't fit everybody with pH crisis. So lower tidal volume and lung protective ventilation strategies are emerged as the treatment of choice. Normal ventilation with PCO2 targeting around 35 to 40 are needed with long respiratory times. And if necessary, during a crisis period, manual ventilation bag could be used. And increase in arterial to end tidal CO2 gradient indicates decrease in pulmonary blood flow. That could be a good marker to monitor. Maneuvers triggering pH crisis should be avoided, and nurses have to be told how to do a secretion in patients who are predisposed to pH crisis. So the important cornerstones of therapy are specific pulmonary vasodilator therapies and the various inotropes and vasopressors. They are the two more cornerstones. Like adequate BP is paramount because preserved RV function, coronary flow is extremely important in this situation. Try to keep SBP more than pulmonary artery pressure if possible. But always remember that there's a reshifting of IVS from left to right side as an important goal in this treatment. And we generally tend to use inotropes to maintain a cardiac output of cardiac index of 2 liters per minute per meter square. But however, we should avoid overzealous use of pressors because we always increase the RV afterload and myocardial oxygen consumption. No single vasopressor has demonstrated superiority. Norepinephrine is generally considered treatment of choice in shock situations. How it seems it doesn't alter the PVR or the renal perfusion. Dopamine and epinephrine are also effective, but they increase the heart rate and myocardial oxygen consumption more than norepinephrine. Vasopressin, there are few case reports that suggest that it actually dilates pulmonary arteries. It's a good systemic vasopressor. We all know that. Agents that are generally considered to be more useful are the milrinone and amrinone. They slow the metabolism of cyclic AMP, which we all know that, and then increases the cardiac contractility. They have lesser increase in heart rate and then augment stroke volume more, and they reduce pulmonary arterial hypertension. So there are theoretical advantages. Levosimendan, the calcium sensitizer that enhances contractility without increasing myocardial oxygen consumption. It is a potent pulmonary and systemic vasodilator. It has potent anti-ischemic effects, and there are several case reports and no systemic studies are available. In the nutshell, the guideline that people refer to, the Pediatric Pulmonary Vascular Disease Network, suggests that epinephrine, positive inotropy increases myocardial oxygen consumption, modest effects on PVR and SVR. Whereas vasopressin, telepressin doesn't have effect on PVR. Norepinephrine and dopamine have good effect on increases in SVR and PVR, whereas milrinone definitely lowers PVR, the caution being systemic arterial hypertension, and levosimendan actually lowers PVR, caution again is systemic arterial hypertension. So in nutshell, the drugs that are very useful will be vasopressin, telepressin, milrinone, and levosimendan. In dobutamine, if tachycardia can be there. Coming on to prostacyclin, anyway, they are not available in India, but then for completion's sake, that can be used. IV epoprostenol can be the preferred agent, but some people now suggest that in this situation, inhaled idioprast through the ventilation can be a more pulmonary specific therapy. Even actually, epoprostenol has been used in inhalation form for this indication because otherwise IV may be associated with systemic blood pressure reduction. There are very few studies that suggest that inhaled idioprast can be effective. The RV function may improve. But it's not available in India. So coming to the most commonly used drug and most commonly misused drug, that is sildenafil, both in oral as well as IV form for this indication. It has a rapid onset of action. It has potent vasodilatory effect and relatively pulmonary specificity is there. But one interesting thought is that pre-surgical prophylactic use of sildenafil is suggested to reduce the occurrence of pH crisis. IV sildenafil is useful, but it's the effectiveness is only demonstrated by few small studies. But systemic hypotension and impairment of oxygenation are the important ones. The studies are like limited. The studies suggest that possibly the time to extubation as well as time up to intensive care unit comes down with IV sildenafil in a small little patients of around 27 patients. Coming to ERAs, that is endothelin receptor antagonist, there is hardly any evidence for its used in an acute period situation in the oral forms, but still we use in some patients. Inhaled nitric oxide is for many considered as an agent of choice because of its potent pulmonary vasodilation capacities, virtual absence of systemic effect because it is immediately inactivated by hemoglobin. It's able to improve oxygenation and then has a good safety margin. There are numerous case reports and small series that are available. So some of the series suggested that 54% responded favorably with 20% drop in PVRI. But one of the most important problems that is seen with inhaled nitric oxide is 2/3 of them develop a withdrawal syndrome or rebound worsening when the NO is tapered off. So there are multiple studies that are available. So there are 210 studies. This is meta-analysis that says this is difficult to draw valid conclusions given the concern regarding methodological quality. None of the studies are able to show a significant difference in clinically important parameters. They all have a modest effect on various parameters. So this is the effect on mortality with INO in pulmonary arterial hypertension crisis. So some of them have tried combination therapies, with a more popular combination being a vasodilatory agent with an inhaled NO with an inotrope like a dobutamine, or sildenafil can be combined with inhaled NO also. So these are the various specific therapies that have been advocated: IV epoprostenol, ileoprost inhaled, or intravenous, INO, sildenafil intravenous, and then oral. So these are the final recommendation for any ICU related PH. So oxygen if there is hypoxia, intravenous prostanoids, and then INO, concomitant sildenafil. So look at it like only concomitant sildenafil use for rebound INO is a class 1 indication. Rest of them are actually class 2B indication where we have to use something. So we always use things. Always remember additional therapies help like BAS and PAHin, temporary mechanical circulatory support. VA ECMO is often preferred even during CPR. If it is instituted, it has a survival rate of around 38%. And then pumpless lung assist devices and lung and heart lung transplantation has to be found. One important thing is that if the patient makes through the pulmonary arterial hypertension, residual pulmonary arterial hypertension, it seems that on the long-term follow-up, some of the studies, the recent articles suggest that the long-term follow-up, the outcomes are relatively well preserved. So to conclude, it's a life-threatening emergency. It has to be treated aggressively since outcomes are poor. Actively look for structural causes, optimize the physiology. Don't treat by reflex, but as most of the treatment that we think that there is no evidence to support. The inotropes and pulmonary vasodilators are the mainstay. The other support devices to be considered early when other strategies fail. So thank you for your kind attention.